It's mainly bike accidents. They have spinal trauma, and it's a very serious injury if it's in a young age. Also, in elderly people, we see spinal trauma because of osteoporosis, because the calcium in the bone is less. So even minute falls in the bathroom or in the home can cause spinal trauma in the elderly. So these two age groups are the age groups where you're going to get spinal trauma, and if it is a spinal trauma, it is a very serious injury, which we're going to learn in a few minutes, right? So this is the overview, what we're going to learn: functions, definition and anatomy, along with the clinical features and management finally, right? So what are the functions of the spine? You already know. It is to allow movement and also for the protection of the spinal cord and the associated nerves. If the protection function is not performed, then the spinal trauma may be increased, right? Also, it provides it allows flexibility, definitely, in many segments like the dorsolateral segment. It is a flexible part of the spine. So you can stretch your spine like this, and you can also bend forward. Next, what is a spinal injury, right? The spinal injury may be defined as an injury to the spinal column. The spinal column has many parts. One is the bony column, or it may be injury to the spinal cord itself, right? So the spinal injury can be divided into spinal column injury or bony injury and spinal cord injury, or both, like spinal bony column as well as spinal cord injury. So spinal column injury are not associated usually with nerve injuries or spinal cord injuries. These are the ones which you get in elderly patients when they have a fall in the bathroom or in their home. Then you get these only structural abnormality, like there's a bony fracture but there's no neurological compromise. So these may be compression fractures of the vertebra. They may be comminuted fractures. There may be subluxation of the vertebra, one over the other, right? Subluxation. Other injuries may be sprains of the ligaments, because there are many ligaments involved. So they may be sprained, and also the muscles may be strained or torn, right? Spinal cord injury, this is the serious injury that we are talking about. It is the cutting, compression or the stretching of the spinal cord due to the injury. This causes loss of function, neurological function, motor function, sensory function, right? It may be caused by the sharp bony fragments of the compression fracture, or it may be due to the hematoma that is forming due to a fracture or due to an injury. The hematoma may compress over the cord and cause this spinal cord injury. So now epidemiology, not very important, right? 50% of spinal cord injuries are complete injuries. Complete injuries means there is total neurological loss below the level of the injury, and 50 to 60% of them are cervical. They are mainly cervical, and these occur in road traffic accidents. Immediate mortality for complete cervical spinal cord injury is 50% if it is a serious compression fracture along with neurological compromise in a cervical spine injury. There is chance of death immediately, because once the cervical section is cut, the functions below the cervical segment is lost. So that includes breathing, that includes the function of the chest wall. So that causes death immediately. So now the types, mainly the maximum number of fractures are in the cervical spine. Thoracic, not very common, because we have the rib cage here. So it gives a lot of stability. Also, it is not a very flexible segment of the spine. So dorsal fractures are very uncommon. Lumbar is there, that is also not very common, but dorsolumbar, because the dorsal and the lumbar spine, they are a portion where a stiff spine, the dorsal spine is a stiff spine, it does not allow flexibility, and the lumbar spine is a flexible portion of the spine. So where they are meeting, the dorsolumbar junction, that is a main cause of fractures or injuries there, dorsolumbar injuries, okay. So now classification, we have the ASIA scale here. ASIA scale, this is the ASIA Impairment Scale. There are 5 classifications, A, B, C, D, E. A is complete. Complete means total neurological loss below the level of the injury. B is incomplete, that is sensory is not there, but motor is preserved. And incomplete, motor is preserved below the neurological level, and more than half of the key muscles below the neurological level have muscle grade less than 3. This is C. And D is also incomplete, where the motor function is preserved, but the muscle grade is 3 or more, okay. And E is normal. So incomplete injury is some motor or sensory functions will be preserved. Complete injury, there is total loss of motor, sensory, distal to the injury. Also, there is something called spinal shock, which usually lasts for 24 to 48 hours. When the bulbocavernosus reflex is positive and no sacral sensation or motor function has returned, the paralysis will be permanent and complete in most patients. This is what we need to evaluate in a patient of spinal injury with neurological compromise. We check the bulbocavernosus reflex, right? If it is positive with no sacral sensation and the motor function has returned, this means the paralysis will be permanent and complete in most patients, right? So, patterns of injury. So, there may be primary lesion occurring between C5 and C7 with secondary injuries at T12. Pattern B may be primary injury at T2 to T4 with secondary injury in the cervical spine. And pattern C is primary injury between T12 and L2 with secondary injuries in L4 to L5 from top to bottom, right? So, acute instability of the spine is caused by the bone or ligament disruption due to the trauma. This causes, there is danger of injury with subsequent loading deformity. And chronic, this occurs in elderly patients. Chronic is progressive deformity that is causing neurological function. This is due to compression fractures which occur in elderly patients. So, predisposing factors, usually in elderly patients, these predisposing factors are present. Degenerative disease of spine like osteoporosis, spinal canal stenosis. Due to slip disc, there is spinal canal stenosis in patients as the age increases, and we've heard of slip disc, so the neural compromise is also present because the nerves are getting compressed. So, this may predispose to an injury later, okay. Ankylosing spondylitis, which is basically a stiff spine. It's a condition where the ligaments are calcified. So, the spine has become stiff and it breaks with very little force. Down syndrome, Klippel-Feil syndrome, Arnold-Chiari malformation, you don't need to remember all this, just degenerative disease of the spine, osteoporosis, spinal canal stenosis, ankylosing spondylitis, rheumatoid arthritis. That's all you need to remember from here. So, now the anatomy you've already gone through in the first year, obviously. So, this is the bony anatomy of the vertebra, right? There are 4 segments, actually 5. And also this is basically a thoracic vertebra that has been shown, and the spinal cord passes through there. Also, we have the anatomy of the spinal cord here, which has the columns, ascending and descending tracts, and when the injury occurs, the ascending and descending tracts are involved. So, this is the bony anatomy that we said, the cervical vertebra, thoracic, lumbar, sacrum, and the last is the coccyx. Each segment is made up of individual bones called vertebrae, and there are 7 cervical, 12 thoracic, and 5 lumbar, as you all know. Stability, okay. Now, the stability concept is an evolving concept. It's basically an evolving concept. You've not heard of this before. So, what the stability concept is saying that when we look at a sagittal section of the spine, this is the sagittal section of the spine, you're seeing it from side, right? This one, right? So, there are 3 columns. This is the anterior column, this is the middle column, and this is the posterior column. So, this anterior column consists of the anterior longitudinal ligament, the anterior annulus, this one is the anterior annulus, and anterior 2/3 of the vertebral body. This is the anterior column. Middle column is posterior 1/3 of the vertebral body with the posterior annulus, that means this disc, part of the disc, and the posterior longitudinal ligament, which is this, right? And the posterior column, which consists of the posterior elements like the pedicles, these are the pedicles, these are the facets, lamina and spinous processes, right? So, and also the posterior ligaments, this is the posterior ligament. So, now any one of the columns may fail during a trauma or an injury. So, injury is said to be stable if only one of the columns is involved. Damage to 2 or more columns, there is a risk of neurological injury. That is what we evaluate when we are diagnosing the patient. We go in for a CT scan, we go in for an MRI, just to see in the sagittal section which column has been injured. If all 3 columns or more than 2 columns have been injured, this patient will go into neurological compromise soon, even if it has not occurred earlier. So, mechanism of injury, how does the injury occur, right? In the cervical spine, there is something called hyperextension injury, which is what occurs in a car driver when there is a sudden trauma, sudden stopping of the car. So, the head goes into flexion and then it goes into hyperextension again. So, this is the mode of trauma in cervical spine injuries, and there may be distraction or hyperflexion. This is basically hyperextension also causes a fracture, and hyperflexion also may cause a fracture due to failing of the columns. Secondly is secondary injury mechanism. That is the primary. The first thing that occurs is that you go into flexion and then hyperextension, and secondary injury is systemic shock, that is profound hypotension and bradycardia. This is the moment of spinal shock. Also, local microcirculatory changes occur due to disruption of capillaries there, and there is a hematoma formation. Also, there is glutamate release and free radical production, which causes secondary neurological trauma. So, primary is the mode of injury that is occurring, the force that is being applied in the first time. Second is after the force has been applied, the may fail, the column may fail, and also the hematoma and all that is being caused there, that may cause neurological compromise. So 25% of spinal cord injuries occur after primary trauma due to the force. And secondary is afterwards, the moment of spinal shock has gone by, then the secondary injury will occur due to cellular hypoxia, oligemia, and also due to the hematoma formation. So this you don't need to know. The factors affecting the severity of a spinal lesion. First of all is loss of neural tissue, which is evident because you will, when the patient comes into the ER, you will see that the patient will only say that I cannot move my hands, I cannot move my feet after the trauma, and you see that there is a trauma to the back or trauma to the cervical spine. Vertical level, higher up the level of trauma, like in the cervical spine, there is greater damage because the neurological functions from that level are lost below. So if it is low down like L1 or L5, then it is just the legs that are involved. But if it is higher up, then the whole function is lost neurological below that level. So what are the features of a spinal injury? The patient will come to you in the ER. Pain obviously will be there. Breathing difficulty in cervical spine injuries. There is sensitivity to stimuli, muscle spasm, the muscles may be stiff absolutely because there has been loss of function, loss of sensation, loss of reflexes. The reflexes will be absent. All the reflexes that you test will be absent below that level. Loss of autonomic activity, loss of bowel control, bladder control, sexual dysfunction will come later. Loss of functions is mobility or sensation, and paralysis. Paralysis will occur. So now the level of the cord injury you have to diagnose from the patient. Before you get any investigations done, you need to come to a conclusion regarding approximately which level the injury has occurred. So the motor level is the last level with at least 3/5 function. You test the function of the muscle, and if it is 3/5, above that it is more than 3/5, like 4/5 or 5/5 power of the muscle, then that is the motor level. The last level with at least 3/5 function. Sensory level is the last level with preserved function. The dermatomes you will be testing the sensation, and the last dermatome where there is sensation loss, that is the sensory level. Radiographic level is when you will get the diagnosis done. You'll get an X-ray, you'll get a CT scan, MRI, then you get to know exactly which level the thing has occurred. And this may not correspond with the motor level or the sensory level. Okay, spinal shock. Spinal shock may mimic a complete cord lesion with loss of motor and sensory function distal to the injury. If the lesion is incomplete, like there is no total segmentation of the spinal cord, then some function will return. Okay? Presence of the bulbocavernosus reflex and anal cutaneous reflex indicates sacral sparing and a more favorable diagnosis. So that's why we always get a bulbocavernosus reflex or a sacral sensation done when we get a spinal trauma patient, just to know if the injury is complete or incomplete. So now we know how the patient will present to us. The patient will come to us in the ER. If it's a young patient, it will be due to a road traffic accident, either run over injury, or it may be due to a bike accident, fall from the bike, or it may be due to a car accident also, like I told you, flexion, hyperextension, that may also cause a spinal trauma. So first the patient is coming to you, or it may be an elderly patient who has osteoporosis, has had a fall in the bathroom or in her home, minor fall. After that, the neurological sensation has been lost, or there is extreme pain. So now we go into the diagnosis. How do we diagnose this? First of all, we go by the sensory level, motor level. We've already assessed that clinically. Next, we go into the tests, what we need to do, first of all, it's an X-ray. It's a plain X-ray, get it done. If you're suspecting a cervical spine, get a cervical spine X-ray done. If you're suspecting lumbar or dorsal, get a lumbar or dorsal X-ray done. AP and lateral, okay. Also, if we see in an X-ray that there is a fracture, we go in for a CT scan and an MRI. MRI will show us the nerves and the spinal cord and how much the trauma is affecting that. So, any type of patient, when the patient is coming into an ER, if it's a road traffic accident, the patient will not only have this, he will have lot more other injuries, like there may be abdominal injury, there may be head injury. So evaluation is very difficult at that point of time. You don't know if it's a cervical trauma, it's a spinal trauma, or it's head injury that is causing the symptoms, because the patient will be unresponsive. So what we need to do is screening. Whenever the patient comes in, get a cervical spine X-ray done, get a lumbar spine X-ray done, and get a pelvis X-ray done. Always get this done. If there is also a head injury, at least these 3 X-rays will tell you if there is any spinal trauma or any hip fracture or anything. So any patient coming into the ER, when the patient has a head injury, has a road traffic accident, bad road traffic accident with abdominal injury also, get the spinal X-rays also done, because we may miss this later on. So this is screening radiology. CT not done usually in an emergency situation. In an emergency situation, we get an X-ray done. After that, if there is any abnormality in the X-ray, to further evaluate, we get a CT or an MRI done later, once the patient has stabilized. And the CT will be more sensitive in diagnosing, because obviously it's a better X-ray, and also it shows you the sagittal sections as well as the transverse and coronal sections. CT misses the soft tissue. So if you need to know the status of the spinal cord and the nerves, then you need to get an MRI done, definitely, because otherwise you will not know which level the injury has occurred. MRI is obviously not an emergency procedure that we carry out. We do it later on. Initially, X-ray and CT scan will be enough. Something called scivora. There is something called scivora. What is scivora? It is spinal cord injury without radiological abnormality. This is something that was earlier only due to CT. So it originally referred to spinal cord injury without a radiographic or CT evidence. Right now, with the advent of MRI, this has become a little ambiguous. Earlier, scivora was a very important term, because earlier MRI was not there, so commonly available. So there would be no abnormality on a CT scan or an X-ray, but there would be neurological compromise. So that was scivora earlier, but now with the advent of MRI, this term has become a little vague, because if any patient has neurological impairment, there will be some changes on the MRI. So MRI will be able to diagnose. So now scivora should be more correctly renamed as spinal cord injury without neuroimaging abnormality. Its prognosis is actually better in patients with spinal cord injury and radiological evidence of traumatic injury. So now we've evaluated the patient. Mechanism of injury we know from the patient. Head injury may cause you to misdiagnose. Head injury will cause you to misdiagnose. So get a cervical X-ray done, get a lumbar spine X-ray done, get a pelvis X-ray done. Decreased level of consciousness of comatose patients may not complain of neck pain. So obviously the patient will be not in a state to tell you that I am having neck pain, or I have the trauma is to my neck. So you need to get an X-ray done. So now the general examination, you get to the spinous process and interspinous process. Palpation is not required. You have to check the reflexes, and you have to check the sensory level as well as the motor level, power of the muscles, if possible. If there is flaccid paralysis, that means there is quadriplegia, that means there has been a cervical spine injury and the whole spinal cord has been transected at that level. So neurological evaluation is, first of all, level of consciousness, pupillary size, reaction, epidural and subdural hematoma have to be evaluated, because there may be a head injury, depressed skull fracture, which is very obvious. Evaluation of sensory, that is pinprick, motor and reflex function needs to be done. And important dermatome landmarks. The nipple line is T4, xiphoid process is T7. These are the sensory landmarks that you need to see which level the sensation has gone. Umbilicus is T10, inguinal region is T12, L1. Excuse me. Perineum and perianal region is S2, S3, S4. So this is mainly a guide. So if the sensation is gone below the nipple line, so that means T4 or above has been affected in the spine. So you need to evaluate this, the sensory management. Now management. we've diagnosed, diagnosis is clear. Now we need to manage the patient. First management is pre-hospital management and second is hospital management. Before the patient comes to the hospital, the patient has had a road traffic accident. So that will be the pre-hospital management. Initial treatment is ABCD, resuscitation of the patient, airway, breathing, circulation. This needs to be done immediately. Resuscitation is aimed at airway maintenance, adequate oxygen saturation. ABCDE, you need to do it first, pre-hospital. Immobilization. If you are suspecting, if the healthcare provider who has gone to the spot before the hospital, the ambulance is gone. If there is a suspected, all ambulances have a hard cervical collar with them. So you need to immobilize it with a hard cervical collar, right? This is a very important thing. If you are suspecting a spinal cord injury, get a cervical spine collar on the patient first, so that there is no further injury after that. Now hospital, the patient has reached the hospital, has come into the ER. Now you're managing the patient. Now, there may be medical management, there may be surgical management. The initial resuscitation is over. ABCDE has been done. You evaluated and you found that there is a spinal cord injury or there is a fracture which is causing neurological compromise. So now what we need to do is, there are two types of management, medical as well as surgical. Now what is the medical management? Conservative management, first is resuscitation, as I already told you, ABCDE. Next is determination of neurological injury. We use the landmarks to get the sensory level, get the motor level right. So T4, T7, you get it done there. So you note down the motor level, note down the power of the muscles, reflex, check the reflexes. And there should be prevention of neurological deterioration by cervical collar or any type of immobilization, like a hard board. If you are suspecting that there is a lumbar trauma, so you get a patient on a hard board. Don't place the patient on a soft bed, because that may increase the injury. So get a hard board or a hard surface. The patient should be lying on the hard surface. And then then basically next step is you prevent the complications. Again, ATLS protocol, ABCD, airway, breathing, circulation, disability, check the disability, expose the patient. Take sedentary survey, okay? Now, in spinal disorders, what we need, commonly practiced things are, we usually don't do all this here. What we do is, we place a collar on the patient. If there is significant trauma, we place the patient on traction. This is the traction that has been given. This is cervical traction, okay? This has been applied on her head, okay? And there is a weight here. So sometimes there is one vertebra comes over the other, known as listhesis. So to correct the listhesis, we need to get cervical traction there. This is the conservative management. Second of all, we come to surgical management. If the patient, one more thing about conservative management is, if the patient has passed the stage of spinal shock and you're seeing that there is some sort of neurological improvement in the patient, then we can continue conservative management with a belt or a brace that the patient may wear, and physiotherapy later on. Now, if we are seeing that there is absolute total neurological deficit below that level, so, and we have a fracture or we have some sort of compression over the cord, we need to decompress that. So, the surgical then we have to go in for a surgery and we need to decompress that portion of the spine so that the spinal cord and the nerves are decompressed. So now it will be considered the spinal cord is compressed and then the spine requires stabilization, because sometimes the ligaments and everything is torn, so the spine is unstable, and in the MRI you are seeing that there is neurological compromise. So you get prepare the patient for surgery, not emergency surgery, but a few days later once the patient has stabilized. So now the surgeon will decide the procedure. The common procedures which we perform are surgical decompression. This all is done here. We do this in our OT here. Surgical decompression, surgical stabilization, spinal fusion, fixation of vertebra and fixation of the spine. Also discectomy, foramen, I'll tell you about all this. Spinal fixation of vertebra, right? How do you fix the vertebra? This is something where there has been decompression has been done. The discectomy means the disc has been taken out, and the foramenotomy means the foramen has been increased. The nerves are passed through the foramen. So the foramen diameter has been increased by surgery. This is foramenotomy. And laminectomy is, the lamina is the portion, this is the lamina. So the lamina needs to be removed sometimes to decompress the spine, laminectomy. And artificial disc implantation, this is an artificial disc. This is the surgical picture inside. These are two vertebra and this is the disc space. We've put an artificial disc implant here and this is the X-ray picture of that same thing, okay. Now, surgical decompression and fusion. Decompression may need to be done for the spinal cord as well as the nerves, and stabilization of the bony elements, okay. Emergent is not usually done, emergency surgery is not usually done. We usually stabilize the patient and then go in for a surgery 1-2 days later. This is laminectomy, right? The lamina has been removed here. If you can see, this lamina has been removed from this. This is the intact lamina and this lamina has been removed. So this is laminectomy to decompress. This is the cord and you're decompressing the cord. So this is a spine surgery being done where the lamina is being decompressed. Also, here are the screws that have been placed. These have been placed for stabilization of the spine if there is unstable spine. And these are the X-ray pictures. One second, I'll just show you. These are the X-ray pictures of after the surgery, and this is an artificial disc that has been inserted inside. So these surgeries are done here. We do this. These are the implants that we use. So now, what may occur after a surgery? Anything related to a surgery may have complications. Complications, first of all, is skin breakdown. There may be infection of the site. Also, there may be osteoporosis and fracture, and you may cause further nerve injury during the surgery or after the surgery due to the implantations that have been done there. So we need to keep this in mind when we are going in for a surgery so that we don't face these challenges. And last thing about spinal injury is rehabilitation. This is a very important part. Even for conservative management as well as surgical management, the rehabilitation part is the most important part of the patient, because the patient has gone through a trauma, the patient has had some sort of neurological instability, some sort of neurological damage, and you've treated that issue, you've either by conservative or surgical management, but you need to get the patient back to her feet, to her daily activities, to her job, to wherever she was working before. You need to get her back to that point. So that means rehabilitation is the most important part. In some complete patients, we cannot get back the neurological function. So in those patients, we need to modify their lives according to their injury, because some patients are wheelchair bound for life due to this injury, and some patients recover well. So when the patients recover well, we need to rehabilitate them. We need to reinstate them in the society, like in wherever he or she was working. She needs to go back to that job. So this is very important part. Rehabilitation, this is usually done by physical medicine and rehabilitation. That's a specialty, and they do it really well. And if the rehabilitation is done well, then the outcome of the patient is really good. So you, either a physiotherapist or someone from physical medicine will be taking over the patient after the surgery, and they will be doing the physiotherapy thereafter. Achha, these are the braces that we use. This is a cervical collar for cervical spine injury. Hard cervical collar, okay? We need the patient to wear this. Second of all, this is a thoracolumbo-sacral brace, TLSO. This will immobilize the thoracic as well as the lumbar spine, okay? It's a very difficult brace to wear, but in some patients where there has been fractures in the thoracic or the lumbar spine, we give this brace and the patient needs to wear it when she is walking around, okay? This is a brace, and also this is a thoracolumbar brace. This is used in patients where there has been no surgery done and there is a fracture, so these braces are used. And the main prognosis of the spinal injury is the neurological compromise. You have to, evaluate the neurological compromise. If the neurological compromise is incomplete and the patient is recovering after the trauma, that is a good sign. And if it is not recovering and it is complete injury, then the prognosis is very bad. Even if you do a surgery, even if you decompress the spine, you may not get the function back. That also needs to be explained to the patient. So pre-hospital and hospital management are both important. Basically, you need to evaluate the spine in a polytrauma patient. Get a cervical spine X-ray done, get a lumbar spine X-ray done. This is the takeaway message. Always do not neglect the spine. If you are suspecting an injury, get the patient a hard cervical collar, get the patient on a hard bed. After that, get the X-rays done. If there is a confirmation, then you go in for further investigations. Don't miss the spine injury, because head injury will, if the patient has head injury, you will not be able to evaluate the spine immediately, but you need to be ready for it. So get these X-rays done, right? And surgical intervention will improve the recovery period. Okay, thank you.